Mouth. Before examining, ask first the patient if he or she is wearing any denture. Offer a paper towel and ask the patient to remove them so that you can see the mucosa underneath. Lips. Observe their color and moisture and note for any lumps, ulcers, cracking, or scaliness. Oral mucosa. Look into the patient's mouth and with a good light and the help of a tongue blade, inspect the oral mucosa for color, ulcers, white patches, and nodules. The wavy white line on the adjacent buccal mucosa developed where the upper and lower teeth meet are related to irritation from sucking or chewing. Gums and teeth. Note the color of the gums, normally pink. Brown patches may be present, especially but not exclusively in Black people. Inspect the gum margins and the interdental papillae for swelling or ulceration. Inspect the teeth. Are any of them missing, discolored, misshapen, or abnormally positioned? Check for looseness with your gloved thumb and index finger. Roof of the mouth. Inspect the color and architecture of the hard palate. Tongue and floor of the mouth. Ask the patient to put out his or her tongue. Inspect it for symmetry. A test of the hypoglossal nerve, which is your cranial nerve 12. Note the color and texture of the dorsum of the tongue. Inspect the sides and undersurface of the tongue and floor of the mouth, areas where cancer often develops. Note for any white or reddened areas, nodules, or ulcerations. Indirect laryngoscopy. Indirect examination of the larynx can be performed with a laryngeal mirror or with a rigid or flexible endoscope. Classic indirect laryngoscopy requires a laryngeal mirror of a suitable size, a head mirror, a light source, and a gauze sponge. Normally, the examination is done with the patient sitting upright after any dentures have been removed. The right-handed examiner grasps the protruded tongue with a gauze sponge in the left hand, placing the thumb on top of the tongue and the middle finger under the tongue. When the tongue is pulled forward, care is taken not to injure the frenulum on the lower incisors. The index finger of the left hand is braced on the upper teeth and is used to retract the upper lip. The light from the head mirror is directed towards the uvula. The reflective surface of the laryngeal mirror should be gently warmed with the hand or wetted with alcohol to prevent fogging by the patient's breath and body heat. The examiner holds the laryngeal mirror in the right hand like a pencil and advances it beneath the palate to the uvula. Touching the base of the tongue or the posterior wall of the pharynx may evoke a gag reflex. The uvula is now lifted on the back surface of the mirror, which is angled approximately 45 degrees, and gently pushed backward and upward so that the larynx can be brought into view. Tell the patient to take a deep breath, and in the phonatory position, have the patient say "he" in order to assess laryngeal function. Besides the larynx, the examiner can evaluate the base of the tongue, the oropharynx, and hypopharynx, and even the anterior wall of the cervical trachea by viewing through the open glottis in the respiratory position. The posterior portion of the larynx are best examined with the examiner sitting and the patient standing with the head tilted forward. The anterior portion of the larynx are best examined with the examiner standing and the patient sitting with the head tilted backward. Keep in mind that this examination provides an inverted mirror image of the larynx.